Good morning to all joining, and thank you for spending the morning with us. My name is Dr. Andy Schumann, and I have the privilege of co-chairing the Clinical Ethics Service through the Center for Bioethics and Social Sciences in Medicine. As part of our Bioethics Grand Round series, we have the honor of a really robust panel with a distinguished guest joining us today. We aim over the course of the next hour to reflect and discuss where we've been, where we've come, and where we're going with regard to the clinical ethics response to the COVID pandemic. I need not summarize nor speak too much, quite frankly, about what the pandemic has done to healthcare, to us individually as well as professionally, but really aim to reflect and provide the insights of some folks who have been at the front line of dealing with this response over the course of the last 14 months. From a organizational flow standpoint, we will start with 3 short talks and then an open Q&A and panel discussion. Please use the Q&A and/or chat feature within the webinar in order to pose questions or comments, and I will do my best to make sure that we address them all in due time. We will be starting with our guest speaker, who it is truly a pleasure for me to introduce. Dr. Necka Cederström is a thought leader and expert in the nation, renowned for her work in clinical ethics, as well as the issues that we'll be talking about today. By way of introduction and background, Dr. Cederström currently serves as the Chief Health Equity Officer of Hennepin Healthcare in Minnesota, and prior to that served as the leader from a clinical ethics standpoint, but also for the Center and Department of Clinical Ethics at Children's in Minnesota. Prior to that, she ran the Center for Ethics at MedStar in Washington, D.C., and her background is diverse in ways that is incredibly important and relevant to the work we're talking about today. Her bachelor's degree is in philosophy. She has a master's in philosophy and a PhD in sociology, as well as a master's in global health. So her breadth and depth of experience really shine, and we look forward to her words and her wisdom today. Dr. Cederström, the floor is yours.
Thank you. And I will do the customary apology, as we all do nowadays, that I currently working from home. We have one sick kiddo and another one who is very concerned about the other sick kiddo. Allergies are hitting hard. It's hard to think about normal illness in the face of COVID, but they may potentially run in here. They're little ones, so I apologize if that's the case, but we'll try and just get through the hour together without any additional disruptions. So thank you all for inviting me to talk. I just wanted to give a couple of comments on my thoughts on COVID, especially over this last year and where we lie. I recently wrote an article entitled "Acknowledging the Burden of Blackness," in which I outlined that by virtue of being born Black in America, one now has what I consider a pre-existing condition that can and will cause suffering in many forms throughout our lives. For Black Americans, the reality of inequity begins in utero for the child. Black mothers cannot just have the usual worries around childbirth. They must also pray that they themselves are able to survive this joyful moment and not become another statistic just because they're Black. Birth outcomes of Black expectant mothers and high mortality rates in postpartum Black mothers tell their story all too well. We all remember the situation that happened with Serena Williams, who fortunately survived, but we can also recite the names of others who did not. Beautiful Black mothers like Shalon Irving, Shaija Washington, and Kira Johnson. As a Black mother myself, delivering my second child in Minnesota, where the outcomes for Black mothers are some of the worst in the nation, the emotional suffering due to that increased anxiety about whether I would survive my delivery and my subsequent postpartum period was very intense. That additional lack of ability to feel in control of my well-being illustrates to me a lot of what our Black families deal with every day, as we all try to navigate the healthcare system that we know is founded and maintained in systemic racism. There's also the everyday casual racism that causes continued erosion of dignity, ability, and capacity. The consistent life-altering complications that occur from bearing burdens of comorbid conditions, that are suffered on Black people due deliberately from racism. Black Americans live with generational trauma weighing heavy on our psychological and emotional well-being. It's one of the many reasons we already have lower life expectancies than white people in America. The trauma has been imprinted on our DNA as the descendants of slaves, and through the colorblind ideology that has been imprinted in the minds of the dominant caste that affects our everyday experiences within the institutions that are built on white supremacy, like healthcare. The distrust of physicians and medical establishments is not simply because of studies gone awry like the Tuskegee experiment, but due to the continuous trauma of anti-Black racism that is prevalent in every medical institution throughout our country. COVID has devastated the Black community, resulting in a drop in life expectancy by more than 2 years. The suffering born of inequality is on full display, illuminating that we are far from eradicating the ever-present pandemic of 1619, while we continue to forge ahead with the battle of COVID-19. To be honest, in a discussion around inequity in Black America and COVID, we must remember first what it means to truly be Black in America. I recently had a conversation with a colleague about creating a statement around health equity for my institution and defining how we will work on it. The colleague disagreed with my framing of inequity in the context of qualifiers like using words of discrimination and poverty. Instead, he wanted me to just simply state that all inequities we're facing are directly related to just racism. Acknowledging the simple yet complex concept of racism in this way is truly able to make a sustainable impact on inequity if we are capable of doing it. We have to pause and appreciate the weight, though, that comes with this identity of Black. This is not something that's taught in school as we become activists in this space. We must do the work, the very, very hard work, to re-educate ourselves out of the miseducation that is still the method used to teach our children. We have an opportunity to quickly rip the Band-Aid off during these days and times and begin the recovery process. COVID-19 is an ocean that we're all in, but some of us get to ride the treacherous waves and yachts while others are barely keeping their heads above water while hanging on to pieces of debris. The ability to pretend one was not aware of inequities in the United States has also ended. Continued ignorance is now a personal choice. I believe most of us will choose to address the injustice presented to us. I don't believe we'll go back to the ways and the days of colorblind leading the tunnel visionaries. One way this is being highlighted is in the creation of new roles like mine in institutions across the country. Bringing together dedicated individuals to work on inequity within the industries, across all industries actually, is an amazing first step. As long as these experts, though, are given resources and authority to actually demonstrate equity in action, I think we can move mountains. I'm concerned with the figurehead positions that are just titles without support or substance, and I urge institutions to be honest in the creation of these roles. If you're not ready to truly address inequity, then don't pretend that you are. In the same vein, there are many who hold the titles and do not engage in the work. There is a requirement of courageousness and activation and to be a motivator in order to make sure that this work can be done. If you're not an activator or a motivator of change, then you should step aside and let someone else who can do that work be in that space. It truly requires getting into the daily grime and getting beat down, and it requires standing up to systems that are so entrenched that it could mean that you're challenging the legality of the situation already. If staying in an ivory tower and using the title to gain personal accolades and a paycheck is the action of a leader in your institution, then I beg you to help make that change. This is the work of amelioration that has to occur. And this is where the concept of medical reparations begins. As I think back over the last year living with both COVID-19 as a pandemic and the 1619 pandemic, the only word I can think of that expresses the feelings of most Black and brown people is exhausted. We are already tired from the constant trauma of being Black in America. The increased anxiety from knowing once again Blackness can be fatal has taken a significant toll. Exhausted, that is the only word that describes it. The time is now to make some lasting impact. We can't let this opportunity go to waste. Our country was able to collectively exhale as of Tuesday. As someone living in the epicenter of all that is going on in this fight and change for justice, I can tell you that it was physically and emotionally hard to get through that day. But the collective exhale helps me feel like there is a positivity around the corner, that we now have accountability for one act, but we need to work hard to get justice for all. Ethicists are not required to study the voices of these people who have been trying to make this work move forward. It's not part of our reading list to talk about inequities in medicine in our undergraduate and graduate studies. As someone who studied a lot of philosophy and a lot of clinical ethics and the issues that we talk about in clinical ethics, it is very clear that this voice is missing. There is a lack of acknowledgement on how important race is in the outcomes of Black and Brown patients. And there's a lack of publishing literature from the very few bioethicists of color who have been trying to scream that this continued oppression from those of us who've chosen work to stand on the side of right just shows us how much decolonizing bioethics needs to have happen. As ethicists, we can't go into a consultation space with Black patients and families and not acknowledge how the presence of white bodies cause physical responses in Black bodies. We can't try to address refusals to consent to withdrawal for non-beneficial treatment in end-of-life cases if we don't first recognize the fear of historical trauma and the primal need of Black families to protect their Black loved one from the white institution that has proven time and time again to not truly care for them. Ethics must own these acknowledgements and bring attention to them. Conversations around non-adherence to medications or difficult families or complex cases with significant social constraints can't truly be done in a vacuum at all. They have to be done with trauma informed. Ethicists first need to do the work to understand how their own existence maintains, continues, and perpetuates institutional racism and the ongoing suffering for Black and Brown patients. That work is hard, but it has to be done. Otherwise, your personal inaction and speaking is speaking for you in these communities, and it's not telling them that you think that they are valued. Trust comes when respect is given and value is felt. We need to set the example of what it means to truly value patients. The lesson from reminiscing over this year that I want to leave with you all is it's time to do the work. As Maya Angelou said, do the best you can till you know better. And when you know better, then do better. Just do better. Thank you.
I think I speak for all of us, Dr. Cedarstrom, to thank you for your passion, for your words, for your wisdom, and for your advocacy. Hearing from someone with such a diverse background of training, experience, both professionally as well as personally, is so very poignant and visceral at this time when many of us are suffering and many of us are challenged to know what we can do better. To hear such a direct charge of what we can and should be doing better is refreshing. Doesn't really begin to start that conversation. We really need to do that work. I hope and I look forward to hearing more from you over the course of the next half hour or so here. But in the vein of doing the work, we would like to present a bit about what we've done here at Michigan Medicine with regard to clinical ethics during and through COVID. And have you help us understand what it will mean to do that work moving forward. With that said, it's my privilege to introduce Professor Janice Fern, who is our clinical ethicist, and allow her to share some of our perspectives collectively as well as her own related to the clinical ethics response to COVID.
Thank you so much. Just give me a moment to share my screen. All right. So just as Dr. Schumann said, I'll give a brief overview of sort of what the last year has looked like for us for our clinical ethics service and some of the various sort of projects and efforts we've taken. So just I'll touch briefly on the ethics consultation portion and then talk about our proactive ethics services. And then just want to briefly touch on our ethics education. And while the sort of broader shift during the pandemic was to public health ethics, away from more the individualized centered ethics, there's still a lot of daily work that we're doing. The workload has been pretty high on the individual patient side as well. And so just briefly, During the last year, we wanted to take a look at the type of consults we were getting and sort of our support and how supported people felt by our services. Interestingly enough, the consults that we had requested were really similar to pre-pandemic types of consults. I think initially we thought that there might be more context, more specific COVID-related types of things. And while COVID played a part, it was more of a contextual feature than the reason for consult. And we found that most providers felt really supported in the midst of all of what we're doing, and that while this was a crisis, it created space for people to be able to pause and reflect about the work that they're doing. Understandably, one of the big things that changed during COVID was hospital visitation and how that impacted patients and families. And so we looked specifically at Michigan and kind of around Michigan, the state of Michigan, what was happening and how different hospitals and what their approaches were. And really then from that tried to make some recommendations, noticing that these policies varied widely and that caused disparities and possible inequalities for particular families. And so came up with some recommendations for how to make those policies more transparent and more equitable. And then finally, in the midst of all of the distress, our consult service actively participated in a number of debriefing sessions and trainings throughout the year, both in person and virtual platforms. And so we're able to hopefully provide additional space for reflection on top of what we were doing through the consult service. From a proactive ethics standpoint, in the last few years, we had started proactively rounding in all of the ICUs where members of the interprofessional team could identify ethical concerns for patients. And as the primary person involved in those rounds, I was concerned that we might have unintentionally perpetuated bias in the initiation of a new service. And so we did compare patients who were identified as having ethical concerns during those rounds with all other patients then admitted to those units. Not for control and for confounders found that it looks like severity of illness is the driving factor for those ethical concerns, and that particularly I was concerned that minority patients and patients of color might be disproportionately represented given the power dynamics between the team and those patients. And so in the end, that's not what we found, but I think that this is a snapshot in time, and it's something I want to continue to monitor and evaluate as we go forward. And then another sort of piece that we were looking at is how is repeat valve replacement for people who inject drugs with infective endocarditis. Historically, they were denied repeat valve surgery, and really trying to take a step back and look at the treatment gaps, possible biases impacting these decisions, and really try to advocate for a multidisciplinary approach and substance abuse treatment being just as urgent as the endocarditis treatment, and acknowledging different policy and advocacy steps we could take so that instead of saying no, we can move to a place of saying yes. That's some more normative work we've done, but that just was recently published as well. And then finally, on the education side, education didn't stop. We were able to move a lot of what we were doing to a hybrid virtual in-person. And this was, I think, I'm glad that we were able to do that and include learners during this time in the service that we were providing. Our pre-doctoral fellowship continues throughout this time. 2 fellows recently just graduated, and we've started a 6th fellow, and our call for applications for that will be going out. And then just wanted to give a sense of who has been on service with us over the last year. So a range of medical students, nurse practitioners, house officers, and social work students have joined us in these efforts as well. Thank you.
Thank you, Dr. Fern, both for a really beautiful summary of where we've been for the past year and for shepherding that effort so clearly and cogently. You truly are an asset to our program. Next, I'm going to transition to Dr. Naomi Laventhal, who is an associate professor in pediatrics in neonatology with a focus on clinical ethics involving children who will be summarizing and reflecting a bit upon the pediatric impacts of COVID over the past year, both nationally as well as here. Naomi, the floor is yours.
Thanks so much, Andy. It's really feel very privileged to be here in this panel and really appreciate the words of Dr. Siedenstrom and the work that Dr. Fern is doing to really keep our organization moving forward in this complicated time. What I'm going to do is a little bit different, I think, in that what I've really done over the last year is think a lot about how this pandemic impacts children in a lot of different ways. And one thing that's interesting as I go through a lot of talks I've written about this over months is that the focus has changed and our understanding of the impact of this pandemic on children has changed. But I'm going to try to give you a very brief flavor of what we've thought about and written about, and also how this has affected our work specifically at University of Michigan. My slides, well, there we go. I have nothing to disclose. So this pandemic really started for me, and I think many pediatric ethicists, thinking about children and scarce resource allocation. And the reason for that, early on, it really wasn't clear that there were profound medical effects of COVID on children. And it's not that they didn't get infected, but they seemed not to get very sick. At least that's what we thought in the beginning. And so we immediately started thinking about our patients who at a baseline require really resource-intensive interventions, both in terms of the materials and equipment and the skilled providers who use those interventions. And it was a really unique moral challenge for us to think about whether our patients were going to have access to those things when there was this huge influx of critically ill adults who needed those resources. And thinking about how that was going to shake out, not with children who also had COVID, but children who had other things that they were going to continue to have as the pandemic raged on. And these are decisions, you know, as a pediatric ethicist, I spend a lot of time thinking about which interventions are appropriate for the sickest infants, and those decisions are really morally fraught. So strain on those resources really changed the way we thought about this, and the prospect of not only is this long odds intervention right for this child, but is it right in a situation where that means an adult with COVID won't get it, or a teenager with COVID won't get it? So that really changed things for us. And whereas I think in a lot of ways the pandemic has reemphasized and recapitulated things that we already knew and were already working through, this idea was really not comfortable for pediatric ethicists and for pediatricians, that we just didn't think about, we didn't have to think about overall scarcity as we thought about what we could do for our sickest patients. And so we think about, when I think about scarce resource allocation, there's sort of, you know, each of these bullets is sort of a talk. But, you know, we thought about what I already mentioned, which is that our understanding was poor about how children were affected when they themselves became infected with COVID. We didn't know about MIS-C at the very beginning. And we learned that there really are important distinctions beyond prestige between freestanding children's hospitals and integrated children's hospitals. And for those who are a little unclear, because we do have our own building, CS Mott Children's Hospital is considered to be an integrated children's hospital. We share resources in a larger adult medical system. And this turned out to really matter as regions and cities and institutions thought about not only how to take care of the patients that they were built to serve, but how to help their hospitals and their communities that were struggling under the weight of deluges of really sick patients with COVID. And one of the things that got said to me a lot was, what are you worried about? Don't your babies have dedicated ventilators, for example? And the fact is that our patients at University of Michigan don't have dedicated ventilators. And the way that Michigan Medicine leverages its resources is by having a single ventilator that serves patients across the lifespan that can be purposed in a lot of different ways. So as we were thinking about this and building our primary COVID unit in the children's hospital, we really thought about competition for these ventilators. I won't get into the various philosophical arguments that have been raised and talked about and how to think about children in a situation of scarce resources. But generally, I'd say the most salient and the one we talked about the most was this idea of fair innings, and that generally we think of children as having some moral claim on longevity. But one thing that was really important and showed, I think, some constraints around this argument when applied to literally is that as pediatricians, we felt strongly that neither an infant nor a 16-year-old has had her fair innings, and that we couldn't and shouldn't play out that argument to its most literal conclusion that a baby might sort of get ahead of the line in front of an adolescent, for example. I've already talked a bit about long shot therapies and how we thought about things like ECMO for children in a situation where ECMO was showing a lot of promise for adults who were critically ill with COVID. And we also thought quite a bit, and this is where I really got to engage with our institution in a different way, about organizational ethics and what was the voice for children on large institutional organizational ethics committees, thinking about Michigan Medicine scarce resource allocations and how were kids going to be considered as we really thought about our own response to the strain on our resources. And so we really had to look in our own, for neonatology, for example, we had to look into our own division and think about what we could offer to help think about our patients in an objective way relative to the entire age spectrum that we serve. And people use the phrase "it takes a village" in a lot of different ways, but one thing that I learned from this is that as the sort of neonatal ethicist in my group, along with Stephanie Kokora, we couldn't do that by ourselves, and we really needed the expertise of our colleagues. And so the top box here is the sort of heading for the supplement that we submitted to our Scarce Resource Allocation Committee that really looked deep into the data and the evidence supporting what we do and the evidence about outcomes for our babies to help make rational and fair decisions about resource allocation. And there was a lot of hand-wringing in the public about the role of preemies, particularly in the setting of strain on ventilators, because preemies who go on to do very well do sometimes need ventilators for weeks or even months after they're born. And this played into an older, longer standing worry about the moral value of babies, particularly the youngest preemies in our society. And so we had to sort of come back and revisit these principles and work with our institutions to think about how we were going to approach this problem. We were also, I think, uniquely affected by some of what Dr. Fern talked about with visitation policies. And one thing that was said to me very recently that I think is really interesting is to ask the question, are parents of hospitalized children actually visitors? Is that what they are? And for institutional and procedural purposes, that's how they're treated. And in the height of the pandemic, we limited visitation to one parent at a time for children who are in the NICU and the rest of the children's hospital. And so thinking about the role of parents when their children are sick, and Professor Siedenstrom spoke about that in the beginning of her talk about her own sick children at home. And when we think about what we feel we owe to our children when they're sick, being with them at their bedside, that's not a visitor, that's parenting. And so when we thought about both limiting parents' ability to do that and limiting parents' ability to support each other through that, particularly in my patients after women have themselves just given birth, often to a child who's sick and in the NICU, we really struggled with thinking about how we could serve our patients, who our patients really were, and then thinking about the inequity that introduced. So my brief story about this is I spoke with one mother at length about her struggles with not being allowed to have her spouse with her as a support person. And she described to me spending almost $1,000 to stay in a nearby hotel with her husband so that she could see him in the evening and come back and visit her baby during the day. And I thought about just the resources that you need to be able to mobilize to do that and the challenges that these limited restriction policies posed on our most vulnerable families. And we've done a little bit of work looking around the country at children's hospital visitation policies. And the point of this map is really to show you that there's no pattern here. And it was really hard to see that there was a systematic or just way that these policies were enforced around the country. Finally, I just want to talk very briefly about the way that this pandemic has forced us to grapple with who are our children to us, what do we owe them, and what do they owe us? And we don't normally think about children owing us things, but when we think about school closures and we think about vaccination policies, the purposes of those things weren't only to keep children safe, they were to keep adults safe. And this headline grabbed me where it says vaccinating kids could be the key to halting the spread and providing herd immunity. Again, that's not just thinking about children in terms of their own health needs, but in terms of their role in families and communities and societies. So I think this has been a really interesting time to think about children in contemporary society. Finally, I just want to point out, and I can't do this topic justice in half of a slide, but that children have not been spared the devastating impacts of inequity and racism through this pandemic, both in terms of how their families are affected, but also in terms of how they themselves get children. So 2/3, and this was a couple of months ago now, this was in September, but at that time, 2/3 of the children who had died related to COVID were Black or Latino. And in thinking about how not only to serve those patients, but how to reflect their diversity in our vaccine trials and how to think about children in vaccine trials, I think these heartbreaking demonstrations of how far we have to go in terms of child health and inequity in child health really came to the forefront. So I will stop there and look forward to a really vigorous discussion with you guys. Thanks very much.
Thanks so much, Naomi. So I have a number of questions that have been submitted, and I look forward to others being shared with us. But I will take moderator's privilege to ask the first question, and I'll address it first to you, Dr. Cedarstrom. I apologize in advance if I'm paraphrasing or misrepresenting your quote, but what I wrote down from what you were saying is that specifically for leaders in academic institutions, if you're not an activator and not a motivator towards equity, then it's time to step aside. And I think that's really a powerful call to action. I would love to learn more from you in terms of what that means in practice, specifically for folks engaged in the work of clinical ethics. What can and what should we be doing on a granular level to activate and to motivate in this current healthcare environment?
Yeah, sure. Thank you. And you got it spot on. I think one of the things that is difficult for clinical ethicists is understanding our lane. We oftentimes believe that our lane is only related to the case that's been asked in front of us, right? Like we have to wait to be called in to address these things. And what I have found, and I've been really fortunate to be able to experience, is there's so much need for clinical ethics to help set the tone, create the rubric or the structure in which organizations need to run. It's more than just addressing the chaotic moment in that one patient's life. That is very important for sure. But if we can establish a foundation within our organization that values the principles around clinical ethics as a whole, then that provides a rubric for all our patients to end up having the best outcomes that they can. And so we need to move out of just assuming that the job is the day-to-day bioethics consults that come in and truly look at what our impact can be at an institutional level, at a city level, at a state level, and forward. And I think that we've been hampering ourselves because we've only stuck to the four walls of the hospital. So with that said, and thinking about how ethics and equity intersect, we have this mantra, sort of this moral duty of doing the best for our patients, right? The best interest of the patient. The patient is the center of all. We can't do that if we don't look at the full picture of the patient. It's not just about picking one thing like withdrawal of a ventilator or not withdrawal of a ventilator. We truly have to look at the patient as a whole and what that meant, what that means, what are their value system, what's their structure, what is the community they come from, what are the additional traumas that they may have faced. Getting into all of those elements, that's when you get into the work of equity. When you start to see how the systemic issues have created the pathway for this patient to be now at the bedside with this conflicting family, then you see where the work is. It can't just be now managing this family that's not wanting to go along with our plan or being unreasonable or just that they don't trust us because they're a Black family. Like it has to be more than that. The equity work lies upstream and ethicists need to go there. We need to look at what are the systems in place with our institution? How are we addressing our patient population? Are there initiatives and efforts that we're working on that are going to improve the external care so that they don't come into our doors with all these additional elements? And we can do that. Like ethicists have the ability to do that. We see things from multiple people's perspectives. We weigh and manage the values. We talk about, management and facilitation of conflicts. Like we can do those things. So combining equity and ethics work, I think, is already there. We just have to get out of our own way and stop narrowing our vision.
Thank you for those comments. And to think what you're talking about really resonates, I think, with the work that where I feel like, we should be, where ethicists should be in the spaces that we should be participating in. And I think hopefully in some of the proactive work we're doing on rounding actively in the units and, being in those spaces. But also I think we've been, that individual case I would say like the personal is political. I think the personal is policy, is all these different levels. And so like that one case didn't wind up there by, by happenstance. There's a series of events and systems in place that impacted the patient being where they are. And so stepping back and realizing, what I think it is our job when we're doing an ethics consult to think about what led to this being the case, and this family being in this really difficult and challenging position, or the patient being in a really difficult and challenging position. And going back and saying, like, what do our policies say? And is this policy, have embedded racism in it? And does it actually treat different people in different ways? Or maybe the policy is sort of, straightforward on the surface, but it actually has really different impact on different groups of people. And then thinking, what does that mean about how people, like you said, come into the system? And I think what I found really helpful is building relationships across the system to say, hey, as I'm seeing these things, inviting people into that conversation and bringing it to different groups of people to just say, how do we collaborate? And how do I better understand how we wound up here? And that's the patient's voice, that's the family's voice, their participants, and huge sources of information for how that works as well.
Thanks. I wanted to follow with sort of two comments about this. The first is that thinking about that patient voice, and one of the, I think, beautiful things about pediatrics, especially in interacting in larger health systems, is that whole idea of who's your patient, and we live in family-centered care, and I think in a very specific way. And so getting those stories and reflecting on those stories, and sort of, in some sense, neither as a doctor nor as a bioethicist, but just saying, what's been your experience of this pandemic, of these restrictions, and reflecting back and saying, what can we learn from that? And I really think that the time that we're in has certainly changed my openness and sort of urgency in having those conversations with families and acknowledging what's happening. And so, in neonatology, we've been faced with, I think, devastating realities of health inequities for a long time. We've understood poor outcomes, both for pregnant women and for the youngest preemies, for a long time. And I, for the first time ever, had a parent bring up to me some of these things in her discussions of her experience in the NICU and say, I've been reading about the outcomes of infants with race concordant physicians or not, and I'm worried about what that means for my baby. And that was an incredibly uncomfortable conversation for me to have, because I don't want that to be true, right? But I think sort of letting ourselves acknowledge that we live here. And I think in our preventative ethics work, we can help our clinicians do that and really say, it's okay to talk about this with people, and it's okay to engage with this at this like individual level about this. And then the other comment I would just make is, Nick, I'm forgetting the exact phrase you used, but have sort of like equity-informed ethics or something like that. I was trained in a model of ethics comes from epidemiology, right? And if you want to talk about a morally fraught clinical situation, you have to understand the outcomes. And I think that's, again, where good data to really understand what the realities are that we're facing and to continue to study this, which means funding this and doing our work where we bring data to the table to think about our policies and think about our ethical analysis, is another way to get at this. And there's I'm biased because I'm a neonatologist, but I think neonatology has a long history of taking on some of these really like tough racial differences in outcomes in the NICU. And so I think that relying on that evidence to inform what we do is another way that we can engage with this as ethicists.
I would agree. And I think that Naomi, you brought up a really important point about patients and families being way more attuned to these things now, right? And so it is a disservice if we dismiss it, right? We have to engage in a meaningful way, because this is an opportunity to actually build relationship and build rapport. Her bringing up to you that she's worried about physician racial concordance is a legitimate worry. Personally, when I went into labor, and from the woman who checked me in on the front desk, every person I met, I just had this mantra, please don't kill me when I'm in here. And my husband, who is white, was very confused as to why I kept telling everybody, please don't kill me. And I had to explain to him because he hadn't read the data. So he's reading the data while I'm in labor, and it's freaking him out, on top of the fact that we're in labor. But And they were kind enough to say to me, we understand that this is really important to you, and it's Minnesota, so there's not a lot of Black people in hospitals as working there. But they found one of the labor and delivery nurses who was a Black female who said that she would be my nurse for the day to help just calm some of that additional anxiety. And I'm someone who had authority and power and privilege and all kinds of things in the hospital that I worked in is where I was delivering. So I had access to everybody to ensure that I was going to have a good outcome on the surface level, but knowing that none of that mattered just because the personal bias and the opportunity for racism to have a play, it was more than I could bear. So just having that one act of having a Black nurse for me throughout the day helped me feel comfortable. And that's an informed person. For someone who's not informed and has no idea, whose anxiety level could make them be seen as not wanting to engage in conversations or being non-compliant with the physicians or the nurses staff or being, whatever term that we use to describe a patient who's just not going along with what we choose for them to do, could be stemming from a fear related to how they're going to be treated because of their color and not seeing anyone around them who looks like them that will give them a little bit of peace. And it's our duty to acknowledge that and know it going in, to be able to name it and say, this could be an issue because every person that is interacting with this patient is all white and this patient is Black, and they may be scared of that simple fact. Not acknowledging it doesn't make it go away. Pretending like if we acknowledge it, that somehow is bad because we're seeing and showing that we see her color, that's not a case. There's nothing wrong with being Black. I have no problems if somebody describes me as Black. I am Black and I am proud of being Black. That's not a bad word. So we need to use that in our practice. We need to understand the data is there, right? We've got a ton of data. And people have been talking about this for years on end, back when it was, the closing the gap of health disparities. It was Healthy 2020. And then we missed that. Now it's Healthy People 2030. And how many years or how many decades are going to go by that we keep repeating the same thing, but still missing the goal? I think we needed something like COVID to make it so apparent to everyone that we no longer can just actively keep going in the same phase. Or unless you just intentionally want to ignore it, right? We have everything in front of us. We have the tools, we have the resources, we have the people willing. We just have to make it okay to start having these conversations and doing things like saying on rounds, which is something that I've started to help establish at my institution now, that as the physicians are rounding, to ask an equity question. Is there anything about this patient's care that you can see has any sort of barriers to success? What are sociological barriers? What could be potential medical barriers? What are cultural barriers? What are family barriers? Is there an inequity in this case? And one of our physicians, our CMO, is doing that every time he rounds. He asks the residents and the med students, do you see any barriers to success here that have an equity bent? And it's very uncomfortable for those students because they have no idea what the right answer is, but they're starting to get okay with saying things like, I think this person has, housing insecurity. So I don't really know if they've got stable housing. So if we discharge them with this med, that may not work, right? That brings the ethics stuff into the conversation. They start looking at ways to truly do what's best interest for their patients and address the things that they can't.
Thank you. And honestly, I think that that's such a personal vantage on what it means to be vulnerable as a patient in a healthcare setting when you don't feel as if your best interests are necessarily going to be heard or listened to is so very important for us all to internalize and hear. And perhaps the answer to that is always yes, there's always an equity issue. It's really more a question of what is it in this particular setting and for this particular patient. I'm going to try to combine a couple of questions together here, and they relate to the concept of how structuralized and institutionalized racism impacts clinical care during COVID in the meta as well as the individual level. So the two parts of this are that we all know that triage and scarce resource allocation, when being done even in a presumably colorblind way, is never colorblind. It is always going to disadvantage folks who are already disadvantaged for any number of different reasons that we've talked a bit about. So how do we move that forward? But I'm also going to share an anecdote that's actually from our own clinical ethics service recently involving a patient with a mental health emergency who needed help at home and for whom law enforcement was called to provide a wellness check to help someone in extremis. And one thing that really opened our eyes was that wellness check means something very different if you're calling law enforcement to go to the home of someone who's Black versus white. That fundamentally, that is a very different type of a phone call and a very different kind of an intervention. And again, getting to the point of, is there an equity issue here? Yes, by definition, there is there. How do these two seemingly disparate experiences play into being the change agent that we need to?
I think the way that I would try and answer that is that we have to see all of the actions that we have to make decisions through an equity lens. And that sounds really, just kind of your standard tagline, but it's true. It's true at just even like just the most simplistic way, just looking at what patient do I need a well person checkup on? What is their ethnicity or their race? Where do they live? What could be their social structure? How is that going to play out? That's a question that should be answered before we do the act, right? Because we have to understand the consequences of that action. Same upstream with big things like ventilator resource allocation and crisis standards of care. We have to look at how the decisions that we're making, the policies that we're putting in place, setting up the treatment, the triage teams and protocols with a lens that says, when we have these people making these decisions, are they given or do they already have the tools necessary to make decisions that truly affect people and the outcome that we want to have happen? And if we haven't done that, then we can't do the act in a way that's meaningful. We would just be perpetuating oppressions. I was asked previously before this started to talk a little bit about this and how do we enact having chief health equity officers or health equity personnel in those decisions to try and help make sure that we look at these things through an equity lens. And even when what we're facing is decisions that may go against what the state has said is appropriate guidelines. And what I want to address that by saying that all of this requires courage, and it can't just be on the shoulder of the person whose title is to be courageous. Everybody has got to be courageous. The entire hospital system has got to say that what we're going to do is we're going to prioritize equity, and we're going to prioritize it in this way. And prioritizing equity does not mean that we're stopping the care for other people. It just means that we're providing the additional services that are needed for some who have been historically or continuously marginalized to bring it up. And I like to say that the goal is to get to net zero. We're so far in the negative that even if we turned all resources to those disadvantaged populations, they're still not going to get to net zero. We have to be intentional and deliberate in our actions to try and raise it up to net zero. So it requires courage and it requires allies. And it requires everybody on the team understanding that although there may be someone whose title is Chief Health Equity Officer, to look and evaluate these patients appropriate for a ventilator or not. And it can't just be a simple yes, no, because some algorithm gave us numbers. The numbers are based off of studies that do not include populations that we're talking about. It's got to be more than just the numbers. And if we fall into it, it's just easier to go by this number system because the number system is equal for everybody. Then we're just perpetuating oppression because we are not equal as people. So we can't be judged off an equal system when there's inequality in the people that we serve. So courage and data and allies all work together to make it truly decisions based off of equity lenses. And when you have that, then you can face issues like a state guideline that doesn't make sense or is perpetuating oppression. I personally have had many, many conversations in Minnesota about the continuation of guidelines that I believe are oppressive. And I've had many conversations with our health commissioner and lieutenant governor and others, and have been the only voice, oftentimes the only one in the room, saying we have to prioritize race in the fight against COVID. We have to. The lawyers are stressed out. Oh, we're worried about the 14th Amendment. And I said, if the Constitution does not allow us to do what we think is the right thing to do, then we have to amend the Constitution. That's why we have that process. It is not a document that is set in stone that can't be adjusted. The reason why we have the 14th Amendment is because it's adjustable. So we need to adjust it, give the lawyers what they need to make that fight to the Supreme Court to change the rules. If the rules right now don't allow us to do what's right, we have to push to get what's right to be done. If the case was that we needed consistency and everybody in agreement and community agreement and everyone thinking it is the right thing to do for slavery to end, I would still be a slave. It's not the cause. The cause is knowing what's right and fighting for it and getting the movement going with allies and courage to get things changed in the way it should be. And I think that we can do that.
So I'd like to ask a kind of follow-up question on something that you just said that really got me thinking about our experience. You know, we framed this talk in the what have we been through over the last year? And I'm thinking about our early days in these meetings where we talked about these scarce resource allocation policies and how we were going to do this. And, you know, well-intended strategies that ended up being the wrong ones. And you said this, you know, do we have the right people at the table, and do we have the tools that we need to do this the right way? And in hindsight, it seems like we didn't. And I say we in the sort of the broadest possible sense, but I guess my question to you is, and maybe this isn't a little fair, is sort of what, if this happens again, and I fear that it will, sort of how would we know? How would we have known? And where did we go wrong in not getting the right people at the table and not thinking about these frameworks in a way? So, you know, thinking about things like SOFA scores, right? I think well-intended people thought SOFA scores made sense. And it turned out that it seemed like the worst thing we possibly could have done. And I guess just with the benefit of hindsight, what would you have advised, you know, Naomi a year ago to say in that meeting?
Yeah, so having lived through those conversations and being at the table when SOFA was even decided as the way to go in Minnesota, I can tell you, when you're in the crisis, right, and it's worried and scared and you have no idea what to do, you fall back on what you think is the right answer, and it's what you're comfortable with. And everybody at the time was very comfortable with the idea of utilitarianism and first come, first serve is bad, but do the most for the greatest amount. That's good. Let's focus there. But that gets at what I said earlier about the reality that we need to decolonize bioethics, because it makes it seem like John Stuart Mill and Bentham were like the only people in the world who understood how to deal with a crisis where you have to think about the big picture of how we're serving. And that's not true, right? That's just not the case. So because we fell into what we feel is the norm, understanding it from a Eurocentric point of view, we made these decisions. That didn't last very long though. And that's the part that I think we need to allow ourselves, is the grace of being able to make the mistake, but then to have the courage to change it. And I think that's where a lot of it fell apart, because when we realized that the mistake was there, it became a, well, now what? We don't really have something that's already been tested and validated, and it's not really like out in an easy public. And it just kind of was a shrug of the shoulder and we'll deal with it next time. And as soon as that started to come about, I started having a lot of conversations with other bioethicists who were thinking about these things from an ethics and equity point of view and saying, if we go along with that, this is going to be terrible for people of color. And we see what happened, right? Like, we know that it was going to be terrible. So you had to start fighting then, but you're now fighting against this system that feels like it's easier to go with what feels normal and safe than to go against the grain with an unknown. And there's scary, and there's fear and worry about, if you go against the grain and an unknown and it's race-based, that somehow means you're going to be targeted and tagged as racist. And that's, of course, right, the worst thing that anybody who is not white that is white can be called, right? If you are fighting a battle that makes it seem like you're racist, you're going to fight against being in that battle, when actually that's the battle we need to be in. So the next time around, because I think that, of course, there will be a next time. We need this intervening space between now and when that happens to develop the tools, to know that what we're doing is to create opportunities to address pandemics from an equitable perspective. There are, I'm sure, hundreds of graduate students right now looking for PhD opportunities. This is one, right? Like, find a tool to help us evaluate mass casualty events from an equitable lens, and then use the intervening time to figure it out, and use the resources outside of just a standard Eurocentric point of view to look at the justifications and the principles and the philosophies behind this. We have the ability to get it done, and I think we will. We just have to now not go back into our usual state of, well, this is done, and so next time we'll worry about it when it pops up, and use this gift of time to fix it for the next time.
Thank you so much. We are winding down. This has been truly a tour de force reviewing such important words. I'm going to give Dr. Cederstrom the last word here, and I'll ask it in a broad question. To end on a bit of a positive note, what are the bright spots for us as a community? What can and should we be proud of that we've done? And how do we use that as a lesson moving forward vis-a-vis the COVID response and our wider eyes with regard to the lens that we need to look at equity and ethics in healthcare?
Thank you. I think that we can be super proud that we have not fallen into the shrug shoulder mentality. I think that once we noticed, we've all kind of stepped up. And the difference is, last year when we were trying to figure out what to do with COVID, and this year when we were trying to figure out what to do with vaccine rollout, very different perspectives. Now we're very clear on equity being important. Our rollout programs that I've seen across the country have been really dedicated to figuring out ways to get at the people that need it the most. There has been less stress about bringing race into conversations this time around. I think over the year, we've learned that it's okay to name it and to address it. And so that is showing up now in the vaccine allocation programming. We have federal systems that are also being very open and dedicated to addressing inequities across the entire healthcare spectrum. We've got the Black bioethicists movement that is going, that I think is also really powerful. And trying to help bring these things to the forefront. And we're having these kinds of webinars that a year ago, 2 years ago, probably would never have had to speak like openly and honestly about ethics and inequity and how we can pull them together. So we've done a lot. We've progressed a lot in a short amount of time, which makes me hopeful for the future. I just think we need to keep it going.
With that, we are out of time. I want to thank all of our panelists, Dr. Laventhal and Dr. Fern, and really give a huge thank you to Dr. Cederstrom for joining us today. Hopefully this will be an ongoing conversation where we can learn with and from you, as well as your colleagues. And I look forward to applying these lessons to COVID-29 or whatever our next challenge will be collectively. I hope you and your family are well and stay safe. Thank you to all for your attention, and have a wonderful afternoon.